Hello, this is David Kettlewell, and welcome to Medical Matters, a nation in debate on healthcare. We wanted to find an expert to speak on medical issues and public health policy, and found it in a gentleman, Dr. Bill Keck. He is an author of many textbooks on public health policy. He spent his entire career as a physician in that particular field. He is the executive producer of a film, Salud, and is known nationwide for having intelligent, well thought out opinions about health care in America. Thank you for joining us. Dr. Keck, criticisms aside that we're reading in the press, what are the needs of the American people today in the area of health care?
Yeah, I understand it's very confusing to many. I think there are at least three basic concerns that we really need to address if we're going to change this health system for the better. And then there are a number of sub-issues as well. But the major thing that people are talking about most, of course, is access to care. How do we take care of those who've had no reimbursement mechanisms to pay for care? How do we control the costs? And that's perhaps getting the most ink these days. How do we control the costs? But then there's something that not a whole lot of people are talking about, which is also important, I think, and that's what do we do to improve the quality? Because unfortunately, despite the general impression that healthcare in the U.S. is excellent, we have lots of information to suggest that it isn't nearly as good as it could be. So those are the major issues. Now there are other issues that come along as well as those, but if people could begin to better understand, I think, how those three play off against each other, I think it's possible that the debate would be more intelligent than often it has been lately.
What's the problem with access to health care in America, specifically?
Specifically, there are probably, it varies of course, but somewhere around 45 million people, maybe 15% of the population, that has no way to pay for care. And since most of them are the working poor, the reality is they can't afford to buy insurance. And if they get into any sort of complications with care and have to pay on their own, they can't afford it, particularly since, in a bizarre twist of the American system, the people without coverage get charged more than the people who are covered for the same services. But there's also an additional group that could be as high as 70 million of people who you would say are underinsured, people who have had pre-existing conditions for which the insurance company will not provide coverage, although they may provide coverage for other issues. So, or folks who have such high co-pays and deductibles that their insurance doesn't come near paying the cost of services that they may require. So you put those two together and it's a third of the population or more that is either under or uninsured. It's a major moral issue in the United States, one that we have failed to come to grips with. And it's certainly a major burden for the rest of us, because when those folks do need care and get it on an emergency basis, then the rest of us pay higher prices for the services we get in order to subsidize the services delivered to those folks.
How do you get control of costs?
A simple sounding question, a very complex one. First, I hope your audience understands that the U.S. healthcare system is a very inefficient one. And it's probably not appropriate even to call it a system. I prefer calling it an illness care industry. It helps understand a little bit why things are the way they are. But we rely for coverage for many folks on private insurance companies. The overhead for private insurance is very high. It's on average around 20% of the money that goes into private insurance companies is spent on things other than medical care. So it's spent on paperwork, it's spent on advertising, it's spent on paying the salaries of a large number of folks whose major job is to tell you what's not covered. or when you do get sick, to look back at your policy and your history to see if they can find some reason not to pay your health expenses. So that's a major issue there. We also have a real hodgepodge of approaches to providing care in the United States. We have a socialized system in the U.S. The Veterans Administration system is one of the premier completely socialized systems in the world, and it gets very high marks. It performs much better than our other private system. We have other folks who are more like Canada, those of us on Medicare. We have a single payer through the government, through the federal government, yet we go to private physicians and hospitals for care for the most part. And then we have others who pay their own way, and then that large group we talked about that seem to have no access to care. The reality is that all of these things create costs then for the providers. We have, as I said, such a hodgepodge that any hospital or physician group practice or even a single physician office has to hire people whose major job is just to keep track of the reimbursement potential, the reimbursement programs that physician has to deal with depending on which kind of patient walks through the door. So the provider side has a lot of expenses in paying people to manage this very diverse group of payment systems, and then the payment systems themselves are so diverse and in many cases with a profit motive built in, and all the additional costs that come with advertising and competing actually cost more than anywhere else in the world.
You've said that the American system is actually a mix of many different systems from around the country. What did you mean by that?
Yes, well, I meant T.R. Reid has just come out with a new book on healthcare. He's an individual who's looked at health systems around the world, and he puts it very interestingly, I think. He says if you're a Native American or in the armed forces or a veteran, then you're essentially in a fully socialized system like Britain or Cuba, where the government manages the hospitals, employs the healthcare providers, and pays the bills. If you're on Medicare, then essentially you have a system that's very much like that, either in Canada, for example, or Canada or several other European countries where we have a single payer, that's the government, but we go for services to private providers, private hospitals, private physicians, and they're paid directly by the government. For people who don't have any health insurance but have the means to pay their own costs, that's maybe 10 or 12% of the population that we have now, we're much more like a developing country that has rich people who can go pay for those services directly. And then for the large group of people who are either under or uninsured, we're very much like some of the poorest developing countries in the world, where these folks have no services unless they're in extremis. Then they can go to a hospital and get served, but they're going to be charged high prices, and many of them will end up bankrupt. Matter of fact, we are the only country, developed country in the world, that tolerates people going into bankruptcy because of healthcare costs. And we have 700 to 750,000 people a year who declare personal bankruptcy because of healthcare costs. That happens nowhere else in the industrialized world.
There are two primary divisions in thought today on healthcare. One of them is to go with a single payer system. Mm-hmm. The other is to somehow amend our insurer-based approach. Let's start with what the pluses would be from your perspective as a public health expert on having a single payer system.
It simplifies things dramatically. It takes away all of the competition, all of the various plans. You end up with one plan. You would end up in a circumstance where people couldn't be refused coverage. or couldn't have their coverage taken away or reduced